On today's episode of Make It Make Sense, Cardiology Edition, we're going to discuss beta blockers. Now, in nursing school, we all had to take a pharmacology class. And in that pharmacology class, we were all given an exorbitant amount of information about seemingly every medication on the planet. At least that's what it seemed like to me. So when it came to learning about beta blockers, I had to figure out how to understand the difference between the cardioselective ones and the non-cardioselective ones. And this is what I came up with. There is a line in Dr. King's very famous "I Have a Dream" speech that goes, "We hold these truths to be self-evident, that all men are created equal." Now, when it comes to beta blockers, that's not the case. So we hold these truths to be self-evident, that all beta blockers are not created equal. Lock in, let's learn. So in the body, we have two types of beta cells. You have beta 1 cells that are predominantly found in the heart. They're also found in the kidney, but that's a conversation for another time. And then you have beta 2 cells, which are predominantly found in the lungs. Now, beta 2 cells can also be found in peripheral circulation. I don't know if they teach you that in nursing school, but this is what I teach to my patients. Both of those beta cells serve a purpose. Right place, right time, they do what they're supposed to do. Beta 1 cells, what do? And what is a beta blocker blocking? All good questions. So, the sympathetic nervous system. The sympathetic nervous system comes into play whenever the body is in fight or flight mode. So if you're presented with a situation that invokes fear or anxiety or something that kind of puts you on edge, the sympathetic nervous system is going to trigger adrenaline release, and that's why you feel like really amped up. When adrenaline is released, the heart rate is going to go up in response. Now, when the heart rate goes up in response, like I said, purpose for that time, the body needs what it needs because it's thinking it's about to go into fight or flight. Nonetheless, if that's not the clinical situation you want for your patient at that moment in time, then you introduce to them the beta blocker. So the beta blocker then the beta blocker will then block or impede that communication between the sympathetic nervous system and the beta 1 cell. This is what the cardioselective beta blocker does. So when the signal from the sympathetic nervous system tries to attach to that beta 1 receptor, beta blocker goes, no. When that signal is impeded, the heart rate will continue to stay low. Or if the heart rate is already high, then, like I said, the signal is impeded, the heart rate is going to come down. And this is why cardioselective beta blockers are an excellent tool to use for tachyarrhythmia management. Now, the beta 2 receptors, which for today's educational purposes, we're going to talk about the beta 2 receptors that are that live in the periphery, in the peripheral circulation. So when that same signal comes from the sympathetic nervous system to the beta 2 receptors, this promotes vasodilation. The blood vessels will open, arteries specifically, but the blood vessels will widen, allow for more blood flow. What happens when vessels widen? The heart rate goes up, right? We talked about that with the beta 1 receptors. So with the beta 2 receptors, when that signal is communicated, blood vessels will dilate open. When you introduce a non-cardioselective beta blocker, these are the beta blockers that don't really work here. They work here. So those non-cardioselective beta blockers will block that signal from the sympathetic nervous system to the beta 2 receptor, causing the blood vessels to begin to constrict. When blood vessels begin to constrict, blood pressure is going to come up. When blood pressure begins to come up, then the heart realizes it doesn't have to work nearly as hard to fill those widened blood vessels with volume, and your heart rate will in turn come down. Now, in what situation can you think that a non-cardioselective beta blocker would be judicious to consider? Think about your patients who may be in rapid atrial fibrillation or rapid flutter, but they're hypotensive at the same time. And on the surface, it may seem incredibly counterproductive to give somebody who is hypotensive a beta blocker. But just go back to what we just talked about. If you are trying to get the blood pressure to come up and get the heart rate to come down, offer for consideration, because you got to do what's right in the clinical context for your patient. But for consideration, a non-cardioselective beta blocker might be exactly what you need. If you can communicate that pathway of information, education to your nurses, and this goes out to my nurse practitioners and my other fellow providers, because sometimes we put orders in and we don't really explain why we did what we did, and then you get a little bit of feedback from your nursing team, and rightfully so. Nurses, you always question orders that you don't completely understand, because you can critically think. All the nurses want, nurse practitioners and fellow providers, all the nurses want is clarity. That's all they want. If you can explain to them and make sense why you implement an order the way that you did, they got you. They are on board. That's a lot of information I dropped on you. I truly, truly, truly hope that it was helpful. I had fun teaching it. Take this information, pass it on to your colleagues. As always, thank you for allowing me a moment of your time. And I bid y'all a happy, happy day. Talk to you later.